Here we have Alex, who is a 6-year-old boy diagnosed with Duchenne muscular dystrophy. He underwent gene transfer therapy at age 5. And after gene transfer therapy, he improved in his ability to rise from a seated position on the floor. His walking was much faster, but he still fatigues after a long day of activity and has some difficulty going up and down stairs. His parents want to optimize his long term outcomes, and so they asked their neuromuscular team what other interventions might be beneficial for him.
Yeah, I think this is a great example that really begins to get us thinking about the possibility of combination therapies for patients with Duchenne muscular dystrophy. I think it's exciting that this patient, Alex, as a 6-year-old male, has been able to benefit from an AAV gene therapy approach. And we actually see gene therapy creating very exciting benefits in terms of ability to rise from the floor, ambulate and walk in a much more functional and normal pattern. But here that we can see that because this patient again was not treated as a newborn, has probably already lost significant portions of muscle fibers. We're hoping that the gene therapy will actually lead to long-term durability and preservation of muscle fibers. This patient is still having some fatigue after a long day of activity and some difficulty going up and down stairs. So I think we need to really think about the potential for combination therapy in this patient. I think one of the first things I would do would be to evaluate his specific genetic mutation for the possibility of adding on an exon skipping drug and determine if he has an exon skip amenable mutation. I think that would be one of the first thoughts that I might have. In addition, with a dystrophin restoration strategy such as AAV gene therapy, I think there's a real possibility that this may lead to benefits in terms of being steroid sparing. So this patient could potentially be treated with an alternative steroid regimen that might produce less side effects and less toxicity. So perhaps a high dose weekend steroid regimen, or perhaps considering transition of this patient to a daily regimen of vamorolone, which might have benefits in terms of his longitudinal growth as well as bone fragility. And then finally, I think as a recently studied small molecule that may have additional benefit in a combination regimen, I think medications such as Javitastat, which is an HDAC inhibitor, which appears to have additional benefits in terms of decreasing inflammation, enhancing muscle regeneration, and reducing and improving the fat fraction on skeletal muscle MRI, and perhaps reducing fibrosis as well as fatty infiltration may have additional benefits. So I would be thinking in terms of a combination approach for this patient, in addition to the standard of care steroids and the AAV therapy, which might include addition of another agent such as a HDAC inhibitor.
As I have these conversations with families of boys just like Alex, I think about the potential for me to optimize long term outcomes in the boys that I'm caring for. Might we be able to utilize different mechanisms of action of therapies to provide that long term optimized care, to provide more durability of improved muscle function and strength? I would take a look at Alex's molecular testing to see whether or not he might benefit from other currently approved therapies. I may consider whether Alex would qualify for an interventional clinical trial. I would discuss with his family the potential risks and benefits of pursuing any additional therapies. And then collectively, we could make a decision on the next best step for Alex given his specific clinical circumstances. Depending on Alex's mutation, we may find that he would be amenable to an exon skipping technology. And these technologies work differently than the gene transfer therapy that he's already had. it would serve to create a different type of a partial length dystrophin protein that could additionally improve his strength and optimize his long-term function with regard to his motor skills, his cardiac function, his pulmonary function. And so if he would be potentially amenable to an exon skipping therapy, I would consider adding that therapy after his gene transfer therapy.
So Alex received gene transfer therapy at age 5, and it seems like he still has some weakness, some fatigue, and he's also on corticosteroids, I would assume, since he has the Duchenne muscular dystrophy. So this kind of goes back to one of the comments that I made, that we know none of the therapies that we have available is a cure, and the future is going to be a combination therapy, combination of whatever options that you're going to choose, a genetic targeted versus a downstream therapy. So I think for Alex, I would probably look at first the steroid that he's on and see if there is any option there to change the dosing or switch to a different type of steroids to see if that would help. And if he has a genetic change that's amenable for one of the exon skipping agents, maybe that's also something you could consider to add on commercially. And then I would also look at any other non-genetic targeted or downstream therapies that's currently available, either commercially approved, I know, or in the clinical trials. At least if you think about it, I don't think there's anything commercially approved therapy that's available, but there are clinical trials that are aiming at non-genetic targeted therapies. Maybe that's something we could consider. And like, Capricor or AgeWise, I know the AgeWise is doing a program on the post-gene therapy patients. That's something that we could look into also.
It's important to have discussions about goals of treatment with any of our patients with Duchenne muscular dystrophy. We must consider that the goal of treatment might change as our boys go through their different phases of their journey with Duchenne. In our boys who are younger and still ambulatory, our goal might be to prevent or prolong their loss of ambulation, to potentially impact their respiratory system such that maybe they don't need invasive or non-invasive ventilation one day. And perhaps we could actually prevent or prolong the time to where they may see cardiac dysfunction. In our boys who have already lost ambulation, it may not be realistic that we return them to an ambulatory phase, but they still have excellent strength in their arms and their hands. And so we'd like to preserve this. Maybe they are not yet on non-invasive ventilatory support overnight. And if we could prolong that, that would be an impressive outcome as well. And perhaps we've been able to stabilize their cardiac function, which is also a success in this phase of their disease. Likewise, in the later non-ambulatory older boys, they may have been non-ambulatory now for well over 10 years. They may have some respiratory dysfunction and some cardiac dysfunction, but they may still have the use of their hands to be able to participate in activities that they enjoy, like texting, communicating with friends, playing video games, working on the computer. And it would be fantastic for us to be able to continue to give them that strength in their hands to be able to accomplish those tasks. In addition, if we could prevent them from progressing even further in their respiratory dysfunction, perhaps they may not need invasive ventilatory support. And if we could keep their cardiac function where it currently is with their current medical management, that would also be considered success as well. So each of these different phases of the journey in Duchenne is going to impact the goals of treatment that we discuss with our patients and with their families.